Hi guys! So today what we are doing is going over depressive disorders, and again I have my notes off to the side, and it's a little bit of a different angle because I thought there would be, did that do anything? I can't tell. Better light over here. And so there's a few different depressive disorders which we're going to go over today, and they all share symptoms of sadness, emptiness, irritability, somatic concerns, which is like physical symptoms, and impairment of thinking. They all impact a person's ability to function, and they commonly come with other psychiatric problems, which is known as comorbidity. And so when you have a depressive disorder, you cannot adapt to stress. It has to be significant enough to be diagnosed. It has to be significant enough to impair functioning. And anxiety and depression together are very common. So what we have is major depressive disorder, major depressive disorder with peripartum onset, which is postpartum depression, disruptive mood dysregulation disorder, and persistent depressive disorder, which was previously known as dysthymia. So first we're going over major depressive disorder. And so the symptoms, you need to have 5 or more of the following symptoms for a 2-week period: weight and appetite changes, sleep disturbances, fatigue, worthlessness or guilt, loss of ability to concentrate, recurrent thoughts of death, psychomotor retardation, or psychomotor agitation. So psychomotor retardation, yeah, it's an odd word to use for that, but it's basically you're moving slower than normal. And then psychomotor agitation is you can't sit still. And then you need to have a depressed mood or a loss of interest or pleasure, also known as anhedonia. Anhedonia. We'll go with that. So this can persist for a minimum of 2 weeks to 6 months. Chronic is when it's lasting more than 2 years, and the recurrent episodes of depression are very common. These symptoms cause distress or impaired function, and it's not attributed to physiological effects. And there's an absence of mania or hypomania, which then would make it bipolar, which we're going to talk about in another video. So once you have depression, you're probably going to have it again. So now on to disruptive mood dysregulation disorder. This is basically childhood depression, but it's more anger-based. Like if there's a minor issue, they will have a tantrum. It's only diagnosed in children ages 6 to 18. The symptoms are constant and severe irritability and anger, temper tantrums out of proportion to the situation at least 3 times per week, and exhibits symptoms in at least 2 settings: home or school, or like with peers or other settings. And management is symptomatic medications, so medications that manage the symptoms, cognitive behavioral therapy, and parent training. And so there needs to be a consistency with positive reinforcement for the behaviors that you want to see again and again. Persistent depressive disorder was, as I said, formerly known as dysthymia. So this is low-level depressive feelings through most of each day for the majority of days. So it has to be at least 2 years in adults, 1 year in children and adolescents. It's less severe than major depressive disorder. It's a lot of times they say, well, I've just always felt this way. It's their normal. And so they must have 2 or more of the following symptoms: decreased appetite or overeating, insomnia or hypersomnia, low energy. Oh, insomnia, a lot of people know that, not sleeping enough. Hypersomnia is the opposite, when you're sleeping too much. That's something I struggle with. A couple nights ago, I went to bed at 8 p.m., didn't get up until 11 a.m. the next morning. So, anyways, low energy, poor self-esteem, difficulty thinking, and hopelessness. Okay, so now this is postpartum blues. This isn't postpartum depression, but postpartum blues, which is just a worry, sadness, and fatigue 1 to 10 days after birth. It happens in 80% of births. It's like stress of adapting to their new role. An important thing to tell these patients is it's normal and it won't last forever. Should go away in a week or two, actually. And so it's probable hormonal changes and, the stress of life changes. And so the interventions that you want to do as a nurse is offering compassion, understanding, support, empathy, and education. So now on to the major one, the bigger one, postpartum depression. Can happen 1 to 12 months after birth. So 11 months, you feel fine. 12th month, postpartum depression. Which is very interesting to me. So the symptoms of this are depressed mood, anxiety, feeling of loss, sadness, and tearfulness, fatigue, irritability, loss of appetite, sleep disturbances, and feelings of guilt. So, the etiology of this, what can cause this is history of previous depression, hormonal response, and lack of social support. So this is common, not common, but it happens in 20% of births. It's more severe than blues, like I mentioned. It varies from day to day. There's going to be more bad days than good days. And your mood might get worse in the evening. It lasts, a difference between postpartum depression and postpartum blues is postpartum depression lasts for a few weeks up to several months. OB nurses should screen for depression, and you have to screen for suicidal ideation. And so you want to notify the provider of risks and symptoms, and then refer to counseling and possible medication therapy. So, on the same thread of postpartum, there's also postpartum psychosis, which the onset is a lot different from depression. It's usually sudden within the first few days or weeks of birth. With this, you need to take suicide and infanticide threats very seriously. The symptoms are severe depression, flat affect, which is when you're talking and there's no emotion, which we went over in the assessment video. Agitation, mania, guilt, paranoia, rapid mood swings, insomnia, disorganized thoughts and behaviors, delusions and hallucinations, and then thoughts of self-harm, suicide, or harming the infant. So what causes this is if they have a previous mental illness, that can be a factor. Hormonal changes, again, and then family history of depression or mental illness. You're going to want to refer to counseling, which is psychotherapy, not CBT, medication therapy, antidepressants, and antipsychotics, and then the safeguarding the mother from injury to herself or to the newborn. So this happens in 1 to 2% of births. If you had it before, there's a 30 to 50% chance that you're going to have it again. And you need to be, they need to be hospitalized. Because it's considered a medical emergency. And so for the assessment for these disorders, you want to do a suicide risk assessment, of course. Their appearance, how's their hygiene, kind of a thing. Is their hair greasy? Is their are their clothes, have they been washed in a while? What is their behavior like? So, inertia, which is the psychomotor retardation or agitation that we were talking about. And then there's also such a thing as vegetative signs of depression, which are decreased or increased appetite. There are vegetative signs of depression, which is when you don't move, you don't do anything. So anyways, other symptoms that I started talking about: decreased or increased appetite, constipation or diarrhea, disturbed sleep patterns, so insomnia or hypersomnia, and then decreased or absent interest in sex. So the first three of those are like on either end of the spectrum. Do they have an ability to feel happy? Like, what's their mood like? Like, do they appear depressed? What's their affect? If they're depressed, it's often blunted or flat. So blunted is when they don't have as much emotion, and then flat is like when there's no emotion, which I think I just said like 30 seconds ago. Anyways, is their affect congruent with their mood? So are they saying they feel happy and they're crying? Are they smiling when they say that they're like they feel horrible, kind of a thing? What are their emotions? Are they anxious? Do they feel worthless, hopeless, helpless? A lot of lists. Do they feel guilt or anger? What's their speech like? It could be slow and soft or monotone. What about their thoughts and perception? They can have impaired thinking and concentration, delusions or hallucinations, and profound depression. And if they have like profound depression with delusions or hallucinations, it may come with psychotic features. And a comorbidity that's chronic pain can be a comorbidity with depression. So you're going to have to give them time to think about the questions, but you may have to repeat the questions as you're doing the assessment. Psychosis increases risk of harm to self and others. So nursing problems related to depressive disorders. So nursing problems are like issues that you see with patients. Like take me for example, a problem for me would be chronic pain. So problems related to depressive disorders are risk for suicide, chronic low self-esteem, imbalanced nutrition, self-care deficit, constipation, disturbed sleep pattern, ineffective coping, or disabled family coping. And so the interventions that you want to do are patient education, which are management through medication and lifestyle, signs and symptoms of relapse, role of medication and possible side effects, using psychotherapy with medications, and identifying and coping with stress. You're going to want to promote physical health, so nutrition, frequent small high-calorie protein snacks and fluids, social interactions with meals, because a lot of the times, like, eating is considered a social activity. And then monitor weight and their eating patterns. You want to encourage them to get up and get dressed during the day, and relaxing activities before bed, and decrease caffeine intake for sleep. Self-care, so daily hygiene activities such as brushing your teeth, brushing your hair, taking a shower, and give step-by-step reminders if needed. And then elimination, their intakes and outputs, high-fiber foods, exercise, fluid intake, and laxatives if necessary, because apparently depression could cause constipation. I guess like not moving a lot can cause constipation. And all right, so that is all that I have for you today about depressive disorders. I hope you like this video, and there will be more to come, probably the next couple of weeks. So I'll talk to you later.